Hi everybody, my name is Garth Gillam. I'm a manager within our health team. I'm here to speak to you about some of the tools for effective financial planning and budget management. Please feel free to ask questions as we go through, and I'll do my best to answer them, and fortunately we've got peers here as well that I'm sure can. I guess on the first slide, there's things that we can control, and these are the tools, and we use these tools to control the uncertainties. And the first tool that we really have is strong financial governance. And what does strong financial governance mean? It means basically recognizing that as individuals and collectively, we have a responsibility for the proper stewardship of financial resources. And in order to have proper stewardship of financial resources, we obviously need to have a very good financial understanding and financial capability, and therefore we need ongoing training. And we need to work together as a team, where finance challenges clinical and clinical challenges finance. And working collectively, that then gives us proper processes and mechanisms to enable us to actually have proper control of those resources. In terms of actual financial planning and budgeting, one of the key things is to have a proper financial strategy that is medium to long term, and that strategy needs to be linked to your service provision. And in terms of actually controlling the finances as well, what we need to really have is integrated financial statements. And by that I mean you'll have an income and an expenditure statement, but it's really about understanding how that income and expenditure statement also translates into your balance sheet and your cash flow. And underpinning that, which we've already alluded to tonight, are what are the key assumptions sitting behind that income and expenditure, and really testing the robustness of those assumptions. So are those assumptions valid for you, and are they also valid for the providers? So for example, on recent work I've been doing at a hospital, there's a classic dispute there on the amount which the PCT assumes they'll be paying, or the consortia, and what the hospital assumes we'll be putting through and building as activity. And it's really about that challenge, and that challenge then obviously needs to inform the contract negotiations, and how much it then costs to actually deliver that activity. Another key component as well, which we spoke about tonight, was the importance of seasonality, and really trying to understand what some of the key drivers could be, pressures that you could have in your year. Because what that then enables you to do is to build in mitigation and appropriate methods for managing risk. Over on top of that then, we also then need to think of further sensitivities, which are mainly things that are outside of our control again, so that we can then work out really what is sufficient contingency in our budget. And some of them can be internal. For example, there could be savings that we plan that we won't necessarily achieve, and then they can be external. So for example, pandemics and so forth. And it's really about trying to have that contingency within our budget. Right. Then, in terms of strong effective budget management and reporting, what this is really about is it's holding budget holders to account. But to hold a budget holder to account means that they actually really need to understand their budget, and they need to have been involved in developing those budgets. And again, just in my experience, mainly in hospitals, again, the key weakness here is where you have a disparity of inputs between your financial colleagues and your clinical colleagues. It has to be a collective effort, it has to be bottom up. That's when people really understand their budgets, more importantly when they own their budgets. But how can they really monitor their budgets? And to monitor budgets effectively, you need proper information, which we've already spoken about tonight as well. And having proper KPI, which are your key performance indicators. And those key performance indicators need to be agreed in the year. And what does that allow us to do then? When we have proper information that we can measure and understand to really determine what the root causes are of variations in year, we can measure that against the KPI, and we can flag risk early. And that's absolutely key in effective financial management. By flagging risk early, we can then develop proper actions to address those risks, and we can also escalate them appropriately to the board and so forth.
How is it that there are PCTs that have run deficits of, up to 80-100 million pounds? If they're doing all this, where have they gone wrong, and what can we learn from that?
I mean, Garth didn't say that they were doing all this.
Yeah, I think that's the key thing.
This is not being rude to PCTs, but this stuff is quite difficult to do. PCTs have a disadvantage because they are not part of the acute trust. So you're trying to control someone else's spend, so it's kind of automatically a bit harder. Well, that's the answer, really, isn't it? Some of them do, but it's
Yeah.
that these kind of simple to understand but quite hard to do things are not necessarily implemented on an equal basis across the country.
I think, sorry, the other thing I'd add is that between PCTs and acute trusts, you can mirror that for years afterwards in a ripple effect in terms of deficit and a pendulum swing of behaviour and financial balance or imbalance between the two, and you can informally map that.
And equally the other way. And much of that is to do by using these tools effectively, right? And by not necessarily having all the relationships good, because they're not all good, some of them are quite difficult, shall we say. But at least they are forthright and upfront, and everybody knows where everybody's coming from.
And the other analogy, sorry, I'll shut up and let you
Yeah, go for it.
is if you take, say, a game manufacturing industry, so automotive, or a company like General Electric that makes aircraft engines, as soon as they've got statistical variation in, let's say, the materials usage of some of these really expensive things that go to make up a jet engine, the accountants are down there on the shop floor discussing with the production managers, what part of your process went wrong? Is it that we're not buying enough materials, or is that a bit that you need fixing? We'll bring in some more. So there's a kind of, finance is a business partner, as opposed to the pen pushers who write the checks and say either you can or you can't spend. I think that's another important point that you'll probably get to.
I mean, just adding to that, we've just recently done quite a lot of work with the Challenge Trust Board on some financially challenged BCTs, and that's really one of the key indicators, which we'll tell you about as well, is really understanding the root causes. And I know that sounds simple, but it's multiple root causes, and collectively that's when the real pressures come.
Absolutely, and it's the organisational and cultural paragraphs of these reports are as strong as the numbers, because that's where the problem starts. And it starts with individuals not understanding what they're doing sometimes, or real mismatches, or breakdowns in relationships as well.
And surely that big sum of 100 million is not just going to be overnight. You wake up one morning, you've got 100 million deficit. It must be increasing month by month by month. So, I mean, who's looking at that?
There are reports we've written about trusts that have suddenly realised they were £20 million out in what they thought the size of the gap was, because the hard accounting stuff hadn't been done right, and it sort of, oh my goodness.
Is that because it takes 2 months to get the activity?
No, and not that. I mean, that's a problem, but that's not the root cause of that. This is proper organisational control and grip.
It's what PLCs would call basic financial grip.
It's basic financial grip and really understanding your baseline. So, for example, in the prior year, if you had a real overspend, a big overspend, what drove that? Was it a one-off event that drove that overspend, or is it something that now is a permanent fixture? It's going to be carried on recurrently year in, year out. Those are then things that then mean you have a baseline that would have to be adjusted in the next year to have a realistic plan.
Get into my mind is the fact that you're commissioning services, you're commissioning pathways, you don't actually fully understand what the contractual implications of those pathways are, because you don't understand what the actual physical things are happening within the hospital. So effectively, the way I see it, the private care trusts are running blind. And the whole problem with QUIP, which we're going to get to, is the fact that they're coming up with savings based on pathways that they don't fully understand. They don't understand what the implications of removing those things. So from a business transformation perspective, they just don't understand the cost of the pathway, the patient pathway. So how the hell can they actually understand what the implications are in year when it's happening rather than after it's happening?
They also haven't engaged the people who are actually signing the release to buy the service, which is the GP. They don't tell me what the price of this stuff is.
No.
It was the one effective thing they've done this year is they've come to us and told us about the specials cost and what specials are costing. And I've been picking up phones to consultants saying, stop setting up my patients to be disappointment. I'm not going to prescribe liquid omeprazole anymore. The minute they told me that, we effected a real change. But they make these plans. So the point is that if we're in charge, at least we'll understand what we're spending.
My view is if you're going to choose a book and you're going to a particular elective to choose something for a patient, the money should pop up there and then. Solid. And then you know what you're spending. Yeah.
So moving on, those are some of the tools, and those are the things that we can try and control. But obviously, on the other hand, we have factors that can really impact and cause variations in financial performance. And some of those things, for example, are management risk, where we've got a difference in our operational and our clinical effectiveness. We could have a demand risk, where there's changes within our consortium catchment areas. Supply risk again, which is actual capacity. Do hospitals have sufficient capacity? And then intrinsic risk, which are things that we really don't control. And again, that's an example, for example, of pandemics, weather related. And it's trying to understand those external ones and how that can then impact on our financial planning and performance in year.
There's a logic to that, there's a
Yeah.
sort of an arithmetic logic,
Yeah.
obviously, but that's not been the experience in the NHS. If you look at Surrey PCT, which is the second largest in the country, you know, it's a basket case. So what you know, I think we need to think about why that is as well, because you also lose things as you gain things with size and scale.
You're 100% right. So it's really, what is that critical size?
This model presumes sort of world-class PLC level FT skills, right? It presumes that all the management structures are in place. It presumes that everybody's looking at the bottom line every 2 bits. Everybody's operating from a P&L. Everybody bought into the budget. Everybody's actively controlling their budget day to day. Without all those mechanisms that world-class companies have, you won't necessarily get that risk apportionment in that way. So it's not fair. I think you need to start looking at it in terms of a mix of size and skill base, right? Because a small operator, as in any industry in the world, a small, slick operator can work as well as a huge global multinational.
That's a very valid
But
point.
it's the manner in which you
What confuses me is that you're giving examples of why this hasn't worked in the past. I'm not sure why giving the budgets to GPs who have no financial skills whatsoever is suddenly going to, all this financial management is going to be okay. Surely it's going to get worse.
Well, we'll come on to
Where
that.
are these people going to come from?
Well, we've got a slide on that in a minute.
The last slide is really there just to stimulate thought in terms of what are the functions that the PCT currently provides, and what do you really as future commissioners understand in terms of what the activities within those functions, and then finally what activities in those functions will you need to take forth, and how will you actually get those activities done? So in other words, is it done at practice level, is it done in a hub that supports the consortia level, or is it actually procured or outsourced? And you know, how will you actually make a decision on which of those functions are critical to performance and things through a series of appraisals and a timeline, and where to actually look for the right people to provide it. And again, it's key really is understanding what the actual activities are within those functions. So for example, a classic one is information and technology. Is that one so critical that that should be something that is controlled by the consortia through a hub, you know, where you've got direct control, or could you potentially outsource that? And I guess it's something around the risk appetite as well for that, and the best way of providing it.
Yeah, there's a risk appetite. There's also who do you think are the best people to do these functions? You're not going to do them yourselves, as your GPs. So who are you going to buy in to do that? And it depends very much on which part of the country you live in and work in, what the kind of political consensus is. Because clearly, you can go to the private sector, so we could do some of that. United could do some of it. I'm very happy to do that for a fee, of course. But equally, there are lots of people in PCTs who do that as their day job. Some of them are quite good. You know, there are obviously huge variation. Some of them aren't. And so you need to make a decision as to what you want these functions to do, write a spec, then work out who's in the market, and then how you're going to do each of these.